Good morning. How was your weekend? Unfortunately, you didn't get to Rusinga. The week was very busy for you, I guess. Yeah. So, welcome back. We want to look at palliative care, but on a small aspect, that is expectation management. The three of us will look at it. Let me present the main issues from the local perspective. When somebody has a chronic disease and you are moving him from curative to palliative care, what does that mean? Yeah, there is a third name there. It's only that it's not visible. That's for Peter. Next slide. Yes, so normally in Kisii, the Kisii context is that chronic diseases are related to some cultural beliefs. So you don't just come and then start talking about care without understanding the origin of that disease. So normally, patients with chronic diseases, they are pulled down by the cultural belief that that is not a disease. Chronic diseases are not seen as diseases. It takes a lot of bargaining, a lot of time, denial, until the patient accepts that this is a disease, and also the family. So the first case, when a chronic disease is detected, patients and their family members, even the community, tend to believe that that is not a disease. It must be either a curse, witchcraft, or some wrongdoing. So, and actually that is the main reason why people present at the hospital at an advanced stage. What is happening is that they are trying to look for alternative options before going for curative treatment. So they might consult a lot, and when it is seen as witchcraft or a curse, that is likely to bring shame to the family. So they don't feel comfortable speaking about it openly. So in palliative care, that ends up bringing, patients rejecting palliative treatment. You will introduce it, but they will say no, because what will the community say? That this is a cursed person. Then sometimes they also think of a patient might have done something wrong. That is why he was punished by that disease. So they are, because of the cultural beliefs, ancestors are there, and also other forms of gods. The belief is that because you did this wrong, the ancestors are punishing you with that chronic illness. So again, if it's a punishment for wrongdoing, you don't expect curative treatment, and that leads to stigma, blame, isolation, and eventually depression comes on board. So you find maybe the patient isolates himself from the rest. The family can be isolated and labeled negatively because there are so many issues that might lead to wrongdoing, ranging from incest to maybe murder and such a wrong issues. Because life is seen as sacred. If you go against it, ancestors will punish you. Then besides that, there is the aspect of cultural diversity. That is now in the hospital when you are offering palliative care. Normally, at that point, the doctors, the caregivers, might not be from the Kisii community. They are from other communities, and introducing the aspect of bereavement what we call one size fits it all. You want to discuss about bereavement for this patient to be prepared, especially in relation to his properties, making a will, or saying goodbye to family members. That is seen as a taboo in the Kisii community. And remember, in the hospital, in the palliative care, you are not having only Kisiis. There are people from Kikuyu. This is a big catchment area. You can find people coming from Bomet County, Kericho, Migori, Homa Bay, and so forth. So that brings on board several ethnicities. So the way they look at bereavement or death is different from what the Kisii people look at it. So if you start talking about bereavement, preparing for death, that will also trigger some issue in their mind, and that is likely to send them away. So among the Kisii community, talking about death is like calling for death. So that is highly prohibited. You leave it like that until the person dies. And the impact of that is there will be so many issues after death, especially on resource sharing for the family, among other issues. The other major issue is that the patient is expecting for cure. But when you are moving him to palliative care, they start wondering, what am I doing here? I want to see a doctor, give me some medicine, I go home, and that is it. But now, putting him aside, you start counseling, you start offering other services, that will raise more anxiety in the patient. Then being a culturally sensitive area, patients also tend to turn to divine intervention, divine healing. And at that point, the patients are slowly coming to terms, they are almost accepting that they have that condition. They have a chronic disease, or they have cancer, for example. Then they start now looking for alternative options which can help in curing the disease. Most of the time, they start attending some prayers. They go for special prayers. They can consult a lot widely. And eventually they turn back to God, knowing that if I pray to my God, this disease is going to be healed. Then finally, there is pressure from the family on the caregivers, and actually the conflict, the major challenge is a conflict with clinical judgment. How clinicians see this condition versus what the family has in mind. Remember, it's a culturally sensitive area. Family members, most of them, will turn back to number one. This is witchcraft, or it's a curse. Why are you giving us these options? So that conflict would again delay palliative care for quite some time. And then finally, patients are expecting free care. So they are looking at palliative care versus the finances they need in coming to the hospital, maybe on a regular basis, for advice or for services. So for them, if you tell them that you will be attending your sessions free of charge, they might accept. But again, the other hindrance will be the distance, where the patients will be coming from. They require some transport, and that will limit access to those services. So those are the main issues, but my colleagues will also add more. Before we move to management, how do we manage those issues?
Okay, Next slide, please. So, for me, when I looked at the issue of expectation management, I felt like there are so many dimensions to the issue. It's a complex issue. There's a matrix of expectations where they begin right from people who are thinking about it, the government, the policy makers. And so I consider the issue of policy as a matter of raising expectations on the part of the patient, and perhaps also the doctor himself should know the kind of expectations which arise from policy. So like now in Kenya, we have the palliative care policy of 2020 to 2030. And it basically prescribes that palliative care providers, one of the issues they raise is that they should explore the potential law of Kenya's indigenous treatment regimen. And I ask, what is the Kenya's indigenous treatment regimen? It's not specified anywhere. And so you're going to see a little bit of some contradiction in that kind of thing. So then it means that our indigenous communities, which are 47 plus, have something to say about how you should be cared about. So there is an expectation underlying in that. Now, and then there is this very nice thing which we talk about, that there is considerations for persons living with palliative care needs. Meaning that I think the hospital, the government, and everyone involved knows what the needs are. And they throw around a few words like they were going to relieve suffering. There is treatment of pain. So avail as many opiates as possible. Then there is the big thing about improvement of quality of life of patients and families. So think about that. So what expectations? So it's like I saw like these statements raise a lot of expectations. Now I can give you a simple example. One time I was listening to when there was a new government in 2002, and someone talked nicely about, I mean, we have reformed the department of offering passports and things like that. You now get your passport, there is no corruption involved. And then that time I wanted to get to Manchester University, and I needed my passport ASAP. Now I applied and I sent in my things and I was waiting. I waited for 7 years for that passport. And so that's why I am I'm not one of, that's one of the other factors I didn't tell you about why I'm not a Manchester guy. The government was part of the disaster. Next. So which expectations did I have? I thought that, we have a new government now, we have moved away from one party politics, okay. So there are challenges, obviously, and I would highlight a few of them. You had them from there. So then when we look at it, we're looking at some papers which are reporting most of this. And one of the things I picked was that there's this statement: so far the research on patients' palliative care targeted at NCD's research has not been attempted in Kisii County. So you will not get any study as such related to NCDs. So you have nothing to go for. So you can think about bringing in money to do it. Then there's this big word, survivorship. And all we have there is there's a need to develop a survivorship care framework. I looked for one everywhere. I didn't see it. But then the complaint rate is that there is a lack of time for the doctors. And I think the question is, when you hear of lack of time, there's the issue is of who? Maybe of the people, and you know our healthcare system, we gave it to you. And knowledge, they hamper optimal survivorship care. Is there survivorship care going on? So working on this will help in maybe managing expectations in the future. Next slide, please. Next slide. Who was doing the slides? Okay, so we looked at another survey, 20 Jeboy et al. It's cited at the end, and you can look at that statement. Traditional palliative care, remember there was a mention of us using indigenous whatever. The traditional palliative care providers share common health-related beliefs, practices, and abilities. All the doctors you are going to meet, all the nurses, all the clinicians you're going to get in Kenya, they share this health. This is something which was done. I'm talking about this rubbish we have in our research, whatever. This claim that we have all this homogeneous belief system involved that influence how they approach and make decisions regarding the health management of their patients, despite marked ethnic diversity. So when you give a statement like that, you are contradicting the fellows who are saying there is diversity. So even this statement itself, you go into the logical root of it, and it starts jarring you. So then he goes on talking about the shared pathways. So which ones? Offer a chance to develop a cogent traditional palliative care service delivery model and health policy framework to promote its integration within the health workforce. So the leading unmet requirements then are knowledge, okay, indigenous knowledge. And then now there's the anxiety yet. Okay, so what about the data issues, intellectual property right? Then disclosure frameworks. How do these patients relate between you and whatever? And what is it you should disclose, what should you not? So there is no disclosure framework. And then ethical regulation principles. Well, we've thrown them around there. Next slide, please. So think about it. So then my reaction was, one of the reactions was that I tried to look back at some of the cases that I know. And then I asked myself, like, if you are a Kisii person who is a parent, what are these things you have, these other expectations, which are cultural bound? For instance, you're going to meet this patient here, a typical, let's talk about this funny Omogusi patient, who thinks, I have this good child, and he or she will provide all the care that I need. But all this care will involve, he has to come and see me, he has to be there, I don't care where he works, I don't know how his time goes, I don't care what problems he has, he will be there for me. It's a very selfish kind of thing. But so then we started then thinking about this issue of birth order and how it affects the family part, because there was the idea of the lives of the family will improve. So then the family has the task of palliative care. But in a typical home, it is going to be either left to the firstborn, because the firstborns are considered to be like the fathers or mothers of, they are the surrogate fathers or mothers in the family. Every problem should be whatever, they should provide leadership. And then, so then, if that is not the case, then there is this favorite child, and in most cases, it is like the one who has been successful among the family now will be the one. I know of a friend of mine whose father is sick. He works in Eldoret, and there are other siblings around. One of them is a head teacher, the other one is a tutor. The head teacher is fairly more successful, but then there's the other thing is, the other one is a good guy. So he kind of, when issues arise, there's a crisis, whatever, he will not call this other guy who's better placed. He will call the other guy because he perceives him as the good child and will do the whatever. But when this other guy who comes in, it's like, I met them the last time, and they're saying, oh, you know, my brother came and he kind of came to the compound and took away so many bananas And then me, I'm coming in and I'm being told, take care of whatever, talk nicely to me. And so it's not the case that all the siblings give equitable support, and there are those who are burdened, and there are those who are eased as per the patient's biases. Let's go on. So these are the references, and let me rest my case at that point.
Thank you, Dr. Mecha. They have almost summarized everything, but I'm coming in to just say a few things. And I'm focusing on key components of expectation management in palliative care. That's the only thing they have not said. But what you need to know, expectation management in palliative care is the process of aligning the hopes, the beliefs, the goals and understanding of a patient, the family members, and also the care team with the clinical realities of the illness trajectory. And now this limits the available treatments. So the key components of expectation management in palliative care: one, you are expected to ensure that there is clear and honest communication. Why is this important? It helps in explaining the diagnosis, prognosis, and what to expect in a realistic but sensitive manner. You know, this particular patient, you treat the patient as if it's an egg. You have to be very sensitive about this particular patient. And again, you need to avoid false hope while maintaining empathy and support. And what you need to know, still under clear and honest communication, you need to ensure that there is the use of language that is understandable, and also avoid medical jargons. Make your language simple for the patient to understand. Component number 2 is understanding patients and family expectations. And as you know, family will always expect the patient to heal. If they are expecting the patient to heal, explore what the patient and family understand about that particular illness. Ask them, what do they know about cancer? What do they know about diabetes? So you identify then cultural, spiritual, and personal beliefs influencing their expectation. That's why we started with social-cultural determinants in the management of non-communicable diseases. So that means you put yourself in the shoes of this particular patient. Then you'd be able to influence their expectation. And again, as you interact with them, encourage open dialogue about fears, hopes, and their goals. Then component number 3, setting realistic goals of care. Why is this important? It helps patients and families prioritize comfort, dignity, quality of life. Setting realistic goals of care also is important because it helps in discussing advanced directives and preferences for care at the end of life. It also helps in terms of reframing goals from curative treatment to patient intent. Number 4, that's component number 4, is about addressing emotional and psychological responses. When someone is affected by an NCD, there are those emotional and psychological issues that come up. So one thing that you need to do, you need to acknowledge grief, denial, anger, or fear that may affect their expectations. Once you do that, then you need to provide psychological social, and spiritual support to help patients and families process the situation. Because for them to process, they have to internalize it. Once they have internalized it, they are able to put forward a way out of their situation. Then what you need to know for you to be able to address the psychological and emotional responses, you need to use what we call a multidisciplinary team. And a multidisciplinary team here, what we mean, you need to have the doctors, the nurses, the counselors, and chaplains. Why do we have the chaplains? Chaplains, they offer spiritual support. Counselors, they counsel. The nurses, you know what they do. And the doctors, you know what they do. So all these will play a part in the life of a patient. Then the last component is continuous reassessment and dialogue. That's why there is always follow-up. You are booked for the next time. When you do that, expectation may change over time as the disease progresses. Then ongoing conversations, they will always ensure that care remains aligned with the patient's evolving needs and wishes. If you are able to do that, then we can say that palliative care is achieving its goal. A practical example, like now here in Kisii, in a rural palliative care setting in Kisii County, or here in Western Kenya, a patient with advanced cervical cancer may believe that traditional herbs or continued chemotherapy will cure her. So expectation management for this particular patient is that you gently explain the stages of the illness from stage 1 to the last stage so that they are able to internalize and understand about this particular illness. Then highlight that the goal now is to manage. The goal is to manage the pain, bleeding, and comfort. Then involve the family who may expect aggressive treatment. You know, some family members are like, if the money you wanted, we have the money here. Can you make our patient get healed? They want instant outcomes, which is not possible. Sometimes, when you are managing an NCD, we had it from the patient's perspective. Then, in supporting counseling to refocus care towards home-based support and dignity in dying. If we are able to do that, then we can say that we are able to meet their expectations. Above all, informed decision-making, unnecessary interventions, trust, emotional preparedness, and caregiver certification are important in expectation management when you are attending to an NCD. Thank you.
Thank you, gentlemen. Thank you. Sorry to have thrown them in half an hour early, but they responded beautifully to what was called upon. Delighted to see the level of development that the principals appear to have here in Kenya. If you compare the Venn diagram of issues presented there with those that certainly I have in the UK, there is a huge amount of crossover. The question really is whether we're able to deliver what we aspire to do. So, the other half, the bit you were meant to hear first, but are now hearing second, we've sorted the technical issues. Diego, can I ask you to take the floor? Thank you.
Thank you, Darren. Sorry, everyone. We had that technical issue. Usually I speak loud enough without the microphone. Could you hear me?
No, we're streaming, so we need you.
I need to do this. Okay. Sorry, yes, we went the wrong order. We should have started from the general to go to the particular in Kisii, but now we go back to the general picture of, and I mean, they've talked about palliative care, right? But do you all know what palliative care is? Yes. You're all medical? No, you're not, right? Okay. So, well, you've been helped now. Please, next one. Yes? Okay. This is the International Association of Hospice and Palliative Care definition of palliative care. Okay? My colleagues, my Kenyan colleagues have told you before, so, but every single word of this definition is important. Okay? First of all, is this one. It's an active care. A lot of people, and I've been in MSF missions, okay, when it's a palliative care patient, we stop taking care, okay? So it's considered to be a passive care and not active. We need to do a lot. We need to do even more for patients towards their end of life, okay? It's holistic, as Anby said, okay? So obviously we take care of physical symptoms. Pain is the most common one, but breathlessness, when we talk about NCDs, pain is not the most important. Well, maybe it is for cancer, you know, for diabetes, between the big four. But for cardiovascular problem or respiratory issues, that pain is not the main symptom. There is breathlessness, there is, you know, nausea, vomiting. I mean, there are a lot of symptoms. But we are not talking about just physical symptoms here. We are talking about, as has been said this morning, you know, emotional, psychological issues, spiritual issues, okay? So it's a holistic approach of individuals. We're not talking about patients anymore, okay? We're talking about people, okay? We have to consider, we should do it always, obviously, at any point of care, but especially towards the end of life. We need to focus on the fact that we're treating individuals. So we have to put ourselves at their place. What would we want if we were in that place? What is important for us? What would be important for us? Just the physical symptoms? No. Okay? So let's consider that we're dealing with people. Okay? Obviously, and this is important especially for MSF. I don't know if we'll have a chance, if we'll have time to go through the statistics of MSF deaths. How long do I have, by the way? Half an hour. Okay, great. So maybe we get a chance to go through some mortality data from MSF. But obviously it involves any age, from neonates to old people, okay? And the focus is the quality of life, okay? But who is the recipient? I mean, as has been said, it's not just the person, but also the loved ones, you know, the people that surround the patient, okay? So this is palliative care. And I was, you know, going through some missions last year, and everybody was asking me, when should we start palliative care, especially for NCDs, right? It's not that easy. When do you know when to start palliative care? Anybody want to guess? It's not an easy subject, I understand, but when would you start palliative care? Please, Anna. If somebody is talking to Darren, it doesn't count though. I mean, he cannot talk. Because I've heard he talked about when to start palliative care in the last week, right? So please go ahead.
In my opinion, it really depends also on the individual itself and their wishes, their ideas of quality of life. So it's tricky to put a like border or like say like, okay, as soon as you have this or you have that it for that person it you should start palliative care. I think it really depends on a patient and their perceived quality of life when we would discuss like palliative care. Of course, there's like at a certain point that we are limited in our treatment options and that we do need to have the discussion like we don't have any other options anymore. Instead of like and the aim should be to keep you comfortable, to give you as much quality of life as we can. But it's tricky to really set a
Yes.
yeah.
That's a good answer. Yes, perfect. There are some, criteria, obviously, depending on the pathology, but they depend on the context. Okay, so to do palliative care in UK is very different than to do it in Kenya or to do it in Afghanistan or to do it in South Africa. So it depends a lot on the context because it depends on what you can offer, obviously. But have you ever heard about the surprise question? The surprise question. No? Next one, please. This is the surprise question. Okay? Would I be surprised if this patient died within 6 months? Once again, the time frame, it depends on the context. In UK, at the moment, the definition of the surprise question is, would I be surprised if this patient died within the next 24 months? Yes, 2 years. Okay? If the answer to this question is no, I wouldn't be surprised. And in our context, where we work, when we treat NCDs, I think you could answer no, I wouldn't be surprised. I don't know, a few cases, right? Okay? I would not be surprised. Well, that's the time to start thinking with a palliative care approach. Okay? But would that mean that I have to stop any active treatment? Because that's another big issue around MSF projects, at least from what I've heard. Okay? There is a net, clear separation between active care and palliative care. Okay? Which is not the case. Next one, please. Have you heard of simultaneous care? I see some head going up and down, but not many. So we should stop thinking. This is the main, the main concept. I want you to go home today. I can talk for hours about palliative care, but I want you to go home with this concept. Okay, we should stop thinking about active care, curative care, and palliative care as opposites. Okay? Actually, especially in our context, the context we work in, they should be provided together. So when the answer to the previous question, the surprising question is, no, I wouldn't be surprised. So I'm not saying I don't have the competencies. I'm a palliative care specialist. I'm not an NCD advisor, as maybe Amulia knows better than me when to stop active care. I don't. But if the answer to the previous question, to the surprise question is, no, I wouldn't be surprised. So it's time to start thinking in another way also. Okay? So please keep treating this patient. If you have, treatments, if you have weapons to, make the disease go slower, use them. I'm not anyone to say to stop. but start treating that patient as a person and not as a patient. Start focusing not just on numbers, on lab values or CT scans or radiology, but start putting yourself in that place. Or tell your doctors, the doctors you are managing, the health workers you'll be managing, to start thinking, this way also, okay? This different approach. So what would you like for yourself? Would you like to choose where to die, for example? I would like to choose where to die. So I would like somebody to ask me. Because if I don't know, well, the first thing is information, obviously, as Anna was saying, if I'm not competent, if I don't have, if I haven't received the right communication, hope. I keep hoping, the patient is the last one. He keeps hope, even the day before death, okay? He thinks he's getting better, if not properly informed, okay? But would you like that kind of death for yourself? I wouldn't. I would like to decide where to die, surrounded by whom, first of all, obviously without pain, without breathlessness, without my physical symptoms, disturbing and suffering symptoms. But on the other hand, I would like to choose things that are at least as important for my life, okay? So we should put the patient in that condition, and we should start thinking when the answer to the previous question is no, I wouldn't be surprised, that we should provide palliative care together with active care, okay? So this is the main concept for today. They are not opposite. Palliative care and active care can be provided together, need to be provided together, have to be provided together, okay? Next, please. And what is end of life? Well, end of life is when you stop active treatment. When you don't, when to provide active treatments, that's mainly for cancer. If you think that way, chemotherapy is not, it can give some side effects and some bad symptoms. So at certain time is not indicated to prosecute it, but it's indicated to stop it, okay? So when you stop and you just focus on physical comfort, emotional well-being, spiritual needs, and practical arrangement in the hours, days, or months before that. So end-of-life care is not just the last hours of that as is believed. Okay? Is everything clear up to here? No questions, no observations? No? Okay. So let's do what, Darren, you want to, no? Okay. Let's see what's happening in MSF now for palliative care, okay? Because we tried, well, I was not there, but a traditional approach to palliative care has been tried during the years, to send the specialist, to send the advisor to implement palliative care. But it didn't work that much. It didn't work that much for a few reasons, for the high turnover that MSF projects have, for the huge competences you need to have to know all about palliative care. And because this type of approach that has been tried was like the one-size-fits-all approach, okay? So we started a couple of years ago mortality data analysis to try to provide a tailored guidance project by project based on what's happening in that specific project, okay? Next one, please. So we studied 3 OCs data to a total of almost 18,000 deaths. These are 2022 data, they're kind of old data. Next one, please. And what we discovered, I don't know if you can see it clearly, but you can see it very clearly here, is actually that 75% of deaths exactly 75% of deaths happening within MSF projects are kids under 5, okay? So they are, and 31, well, here, 1/3 are neonates, more or less, okay? It doesn't have much to do with NCDs, but you are MSF managers, okay? So you need to know what's happening in your projects, okay? And why did we do that? Once again, I told you, because we thought that by providing the health workers with the 350 pages guidelines that are there, I don't know if you've ever accessed them. They are beautifully done. They were done by OCBA. There are 350 pages of palliative care guidelines, very complete, very well done, perfect. I don't know everything that is written there, okay? They are very well done. But see, your manager, your doctors, your managers, you've never accessed them, okay? There are too many. Who is going to study 350 pages? You're going to forget them, okay? So instead of providing palliative care valid for every single clinical case, we thought, well, maybe if we study the mortality pattern of that specific department into that specific project, we can provide the health workers working there just with what they need, okay? And that's why we went on. Next one, please. Working? Maybe I just keep it too far. That's why it's not working. I'm lost. Next one, please. That's, and then we decided to study, because when we started studying these data, we said, well, but people are not dying anywhere within the project. There are typically 1 or 2 or 3 departments where that happens. So we don't need to teach everybody about palliative care, but we need to focus on those people working on those departments, maybe, okay? So it's a more focused and targeted training. Last thing we did, next one please, was to study, well, but what are we talking about? Are we talking about palliative care, which is a broader aspect, as we've seen before, right? We just saw that. Or are we talking about end-of-life care? Okay, and what we discovered in inpatient facilities, and this is valid for NCD also, I mean, not when we follow them on outpatient departments, obviously, but when they get in the inpatient departments, in 73% of cases, we're talking about people dying within 72 hours from admission in the hospital, okay? So it's very late, okay? They get to the hospital very late, and actually what we need to provide is end-of-life care. Once again, why did we do this? Because it's interesting on one side, it can help us to organize things, to organize the projects in a different manner, but also from the strictly palliative care point of view, I mean, the needs emerging in these hours are much different than the needs emerging in a much longer period, right? And consequently, the needs of the staff are very different. I don't need to teach these people rotation within oral opioids, okay? In 72 hours, I just need to teach IV therapy or subcutaneous. I don't need to teach anything about oral therapy, for example. So I can provide, once again, next one please. Well, maybe we go too deep here. Next one please. So we developed this app. You'll have it soon. Okay, soon I hope. Maybe next year. But we developed this app that is fed directly, automatically from DHIS2. You all know DHIS2, what it is, right? It's the, you know, the database where all the data are recorded within MSF. So it's fed directly from DHIS2, and from the mortality data coming from DHIS2, it gives you an indication of what type of palliative care is indicated to implement in that specific project. So when you are managing one project, when you are a head of mission, when you are a medical coordinator, when you are an MTL, you can access this app, and this will give you what type of palliative care is indicated based on the mortality pattern that specific context is facing. Okay? Next. I'm kind of afraid. I don't remember what I put next. Well, it doesn't fit in the, well anyways, I'll tell you what is written in here. Oh yeah, you can read it there, actually. It doesn't fit here, but there and there, yes, you can see. I told you that the goal is to provide you with tailored guidance, tailored, you know, guidance package, knowledge package, training package, which is based on the mortality pattern we were talking about. So who is dying, where is dying, and when is dying? This, you know, gives you a quite clear indication of what type of palliative care is needed in that specific project, but also tailored on the social anthropological context. I mean, our colleagues here from Kisii were saying that to do palliative care in Kisii is very different than to do it even from, you know, a county nearby, okay? And you can imagine in the context where we work, to do palliative care in Afghanistan is very different than to do it in Kenya or to do it in Southern America, okay? So, and that's why we're working with the MSF East Africa Anthropology Unit to trying to provide you with a basic approach, but based on the context where you will be implementing palliative care, and on the roles, okay? All these people need to know something about palliative care when you're implementing it, all of them. But do they all need to know everything? No, they need to know different things. Well, these need to know how to, you know, put up a palliative care service. That doesn't need to know anything about clinical stuff. This one needs to know how to import drugs, how to build a team, you know, but doesn't need to know necessarily anything about clinical stuff. The medical doctor needs clinical stuff, but just based on the pattern that we were talking about. So if he's dealing with kids, he doesn't need to know anything about adults. So it will come out, you know, these kind of recipes that I tried to show you on the side of on the slide, that are really tailored based on the mortality patterns, on the social anthropological context, and on the role, okay? But everybody needs to know, not just the clinical team, as we said, because it's a holistic approach. We need mental health counselors, we need the health promotion team, because you cannot do palliative care unless you do community engagement, right? We've been hearing about it. I think I would stop here. I've talked too much, maybe. You'll be informed about the progression of this project, but I want you to bring home today is the first part, okay? The surprising question, what it is, and stop thinking about palliative care and active care as opposites. You have to provide them together, okay? Thank you.
Okay, if I invite my colleagues to have a seat, and we'll open it up for some questions and some discussion. Just move this out. There you go. so you're not in the screen. Samuel, you're coming to join us? Okay. Slightly the wrong way round to the plan. We were originally wanting to do the strategy and then drill down to the local. But overall, that was a really interesting exposition. And the thing that stood out to me was that graphic where the number of patients who are dying within 72 hours and the end of life care. For many of us, I think end of life care is what we label palliative care, but palliative care can start weeks, months, and potentially even years before they enter the end of life care phase. So, let me throw it open for questions. You have a question on the front? You're holding the microphone. I thought you might. Anybody have any thoughts? Anything you want to raise? Microphone. Oh, Hikmatullah, go on first and we'll get a microphone back to Anna. Hikmatullah.
Good morning to everyone. My question is mainly for Diego. I just recently met him and I heard from you that you are about to start palliative care in Helmand project in Afghanistan, and someone is already specified who is going to visit soon. The first question would be like, MSF has been there like for more than 15 to 16 years. Why are we thinking about this so late? I mean, despite having the data and everything, and you know that the mortality rate and all these things in Helmand is very high, but we are thinking about this very late. That is the first thing. Secondly, I mean, on higher level, it is already identified that we are going to start this thing, but on project level, nobody knows. So that prior communication in the projects where we have a foggy picture of what is going to happen, and also when suddenly somebody comes into the project and we see who is this, and everybody then knows when we see them physically that he has come for this purpose. So if we can have a prior kind of something in the projects where we can have somehow a foggy picture, so it will be easier for the person who is coming in. But when suddenly things are decided on higher level, but on project level nobody knows. So like, how would you respond to this?
Is it on? Yes. Well, to your first question is, I'm not the best person to answer. You know, I've been joining MSF specifically for this project. Okay, I've never worked for MSF before. I worked for a humanitarian organization, but never for MSF. And actually, was quietly working in Italy when I decided to apply for this project. So I don't know. At a certain point, they decided to, you know, take this different approach. It's not. They've tried to implement palliative care. Maybe not in Afghanistan. They did it. There are projects that are running palliative care, like South Sudan. For OCA, there are OCP's projects, especially Malawi, which is a specific cancer project. Homa Bay is running some palliative care also, as far as I know. But they are not very cost effective, you know, not cost in terms of money necessarily, but there are not even enough specialists in Western countries. Okay, so this time what has been decided is, well, maybe instead of once again trying to approach it in the traditional way by sending a specialist, we should provide the people already working in the project with basic competence of palliative care. Even from the philosophical point of view, this is quite important, I would think. I mean, as health workers, I think everybody should be able to deal with death. Death is embedded in clinical practice. Wherever you practice medicine, you will face death, okay? And it's a shame from my point of view that even in Western countries, palliative care is just on palliative care specialists' shoulders, you know. My dream is that palliative care specialists disappeared from the face of, you know, from the world, because health workers should know how to deal with death, should consider that, should stop thinking that as a defeat. But we've been trained all that way, you know. In every country, if you see the curriculum studiorum of a medical school, you rarely talk about that. Sometimes nurses do, but doctors no, because that is a defeat. Okay, so this is a different approach. I got lost again. Yes.
Should I take that back? Diego has a strategic role and you're an individual mission. So let me come back to all of you who would like to ask that sort of question. Why don't we know? This is a master's in humanitarian practice. You are being developed to be the leaders of the future. So why are you waiting? Why are you not asking for what you see you need? And I'd ask you to reflect on the fact that there is a big initiative coming and that the large organization is trying to respond to the perceived need. And I don't mean this to be accusatory, but why do they have to give it to you? Why are you not recognizing it and asking for it? Subtle adjustment in the perception. I don't mean it to be accusatory to yours. It's a very legitimate question. Why is it not already there? But as Diego's talked about education, doctors never give up. Well, they do, but they're taught don't give up. And the patients and the relatives, as we heard from our Kenyan colleagues, the families don't want you to give up. We've all had situations where I have them in the emergency department where you're looking at somebody and think, you're dying. This is a dying process. And the family are wanting you to do things that are not in the patient's best interest. And that's a difficult line to walk. But it belongs to us all, not why is it not being given to us? We should be asking for it. So I don't mean to put down, but it's a reflect on why you're hearing about it now and not asking for it. I'm going to go to Anna at the back. Anna, you had a question.
Yeah, I actually have two, if that's allowed.
Two?
Yeah.
Okay.
The first one is actually about the first presentation on the expectation of free care. I think Dr. Peters mentioned that, and that's one of the challenging parts. And I was wondering what his opinion is on MSF or other NGOs providing free care and what that does to that expectation.
And your other question?
The other question is for Diego. I think for me as a doctor, MTL, one of the biggest challenges around palliative care has been, especially when you're setting up a context or like setting up a mission in a new context, is investigating that socio-anthropological context. What kind of values are there in a context? And I was wondering what kind of tools maybe there will be in the app or how we should approach that. Because I think that for me, like you have the knowledge as a doctor and what to do, but it's more the socio-anthropological context which is challenging to me.
Okay, thank you. So we'll go to our Kisii colleagues first. Perspective on free care. Who would like to take that? You can try.
I can. Yeah, I can try. What you need to know is that if in expectation management from the social cultural point of view, you as the health workers, you need to be capacity build so that you know the entry point. You know how you are going to deal with this particular patient. You don't go, that's why we talked about avoiding medical jargons when you are explaining to this particular patient who needs palliative care. So if you have conceptualized those social cultural aspects in you, you know how to access the patient, how you set base, you talk to the person before you move the patient to the next level. That's what I can say.
Okay, Diego, tools and values.
Um, well, we are trying to keep that thing simple also, and more than giving answers, teaching you the right questions to ask. Okay, so that's the kind of approach that together with the MSF East Africa Anthropology Unit we are trying to prepare. Okay, 90% of the staff is usually locally hired staff. So the first suggestion is trust them more than yourself, because we tend to give the approach we're used to or to the previous mission, but there is community engagement always in all MSF projects. So we need to go through that. Obviously, we asked the MSF Anthropology Unit of East Africa to prepare something like please develop for me culturally relevant messages about access to palliative care services and benefits of seeking care for the community. Advocacy and public awareness of unnecessary suffering for patients with life-limiting illnesses is another one. Active sensitization about aim and scope of palliative care. So is something going towards the direction from health workers to the community, explaining what palliative care is and what is the aim and the scope of palliative care, but try to absorb from the community, who should we talk to, sometimes it's the mother to decide for the kid, sometimes it's the father, sometimes it's the spiritual head of the town. So we don't know that, but if we have the right question to ask, we can set up that part too.
I think the issue of free things is interesting as such, and the whole idea is that every patient, I think, as the way they perceive themselves is that I'm the needy one, and this way I think the religious aspect comes in, and maybe a personal idea of like I should be helped, have a proper mind. The whole idea is if you're really caring for me, then you should not do it at a cost. But the whole idea is like then what comes in is that they have that expectation that I'm not going to pay for it because I'm the sick one. I do not have the time to look for the resources to do it. And so around that, someone has to pay for it, and most people now go into WhatsApp groups to raise funds and what, because essentially the patient never pays. I'm sick, I get on the bed, deal with it.
Okay. We have hands up everywhere. I'm going to go to Emulia first. Can we get the microphone across to Emulia, please? Oh, I'm sorry. Do you want to ask your question first? You were waiting. Then we'll go to Emulia.
Yeah, I can wait.
Away you go. You were very patient. I'm sorry.
Okay, good morning and thank you for the presentation. So my question goes to the Kisii team. So when mentioning the palliative care policy in Kisii, you mentioned that palliative care health providers are expected to explore the potential role of Kenya's indigenous treatment regimen. So what I want to know is there like a body guiding the activities of the Kenya's indigenous treatment regimen? Because I feel like it's a form of complementary care, right? Just like acupuncture and other forms of complementary care. And are there studies being done to like assess the quality of such form of cares? Or is it that we just, I don't know, because I'm finding it difficult to understand how you kind of integrate the conventional palliative care with those indigenous treatment regimens without, because in Africa we don't study a lot, we don't research a lot, so I'm thinking of the ethical issues that can be, I don't know, that can arise in such things. These are herbs and probably these are things that have not been studied, and then this is the nation telling you to explore it in the management of palliative care in cancer. So I'm a bit concerned. And another thing is, I don't know, we are battling with people going for traditional care instead of the conventional care. And then we are now like integrating the two. Aren't we afraid that in subsequent times, patients with cancer would rather go to the alternative care medicine instead of the conventional care? I don't
Okay,
know if-
thank you.
Thank you for the concern. Maybe there are two layers into the issue of indigenous regimen. I think for a long while, I think I can't put a date to it. They got to this point, I think, somewhere early 90s, where there was an actual bit of taking those people who are called herbalists, okay? And I think Kenyatta University still has a program where they actually train them. And like if you open that a TV set in Kenya and whatever and watch throughout the day, probably you'll get to a point where a person who has no medical training comes on board, Dr. Marungu, is that it? And they have been given titles like doctor and professor of herbalists, but they are affiliated to a kind of a known society, and they have their days. I think in the course of the year you'll find they are in Kisii, they go to the Kisii Stadium, and you have an array of all these people who are recognized herbalists who supplement the medical whatever. And they and like now, I think there's one, you go to the stadium who has an office there and whatever, and he will tell you, I have been trained in whatever, and I got these refresher courses where we are involved. So, but the problem is, who are they?
Yeah, just an addition. Actually, literature has it that Kenya is the first African country to adopt and implement palliative care, but through the Kenya Hospices Association. But the indigenous approach is a complementary to the current palliative care. And actually, if you go to, we have a Center of Excellence in Research known as Kenya Medical Research Institute. It has several centers. One of them is a center for traditional medicine. And then currently, the government has regularized an association known as African Indigenous Knowledge, which is trying to train more people on complementary medicine.
Okay, I think we need to keep moving. And I would say to people, think about your patients when you give them the news that they are in the final stages of life, that they are palliative. Does it really matter if they use complementary care? Because we've already reached the limit. We know our medicine is not going to cure them, and it's about how they feel and what they believe that really matters. That's just something from me personally. I'm going to go to Amulya. Amulya, did we get the microphone to you?
Yes, thank you. Are there other questions, or 'cause
There are
I
lots of
just-
questions, but I chose to go to you because you were enthusiastic.
Well, I wanted to underscore, as the old timer here and someone who was part of these early efforts at palliative care, and even getting palliative care on the list of MSF activities took a long time because of our list is already long. But one thing, and I'm very happy to hear everything Diego is saying, because some of those early projects, there was sort of one person designated for palliative care, and of course it didn't work because it takes all those different roles and inputs that are going to be defined better on the app. And then the other thing is, so for adults, when we're talking about person-centered care in MSF in general, it's what Darren just said. You're talking to the individual and finding their preferences, and that helps a lot, of course, if it's someone who's not in a position to make a decision already at end of life for a child. Then we hopefully also have more of the anthropologic support, the social science support now.
Thank you. We had a whole forest of hands earlier. Hands again for questions. Could we get up right in front of you, and then I'll come across here.
Thank you very much. I just have a quick question to the Kisii team. Knowing that palliative care for us, it's, as medical practitioners, it's a difficult subject to reconcile with. There's a lot of conflict within us in terms of accepting this and also being able to make the family to accept. I'm wondering if, as Kisii County or as Kenya, are there some tools beyond just the policy that is there? Are there some tools to help the health practitioners know how to deal with this subject of palliative care, but in terms of being comfortable with it and being able to communicate with it? An example I'll give in MSF is that the team is trying to have like exploration of values, like values and attitudes towards palliative care, workshops being done for health workers to appreciate this. I'm wondering if Kisii, do we have some tools to help?
Thank you. What I know, we don't have standard tools to apply into that, but we have organizations like AMREF who have been in handy in terms of integrating palliative care in their trainings. And you find that, especially when they have trainings for CHVs, medical practitioners, they integrate this. And you find that we, like now the anthropologists, we are asked to come in and give trainings in topical issues like what we have trained today, so that the social-cultural aspects can be integrated when they are handling patients. Thank you.
I think there's this bit of when do you talk about death involved in that. And it's one of the things, like, I remember the last time when we had an MSF meeting and we had the issue on palliation, and someone was like, so is there then that dimension, like now for a doctor, where you have to think, what's my philosophy of death? And that is something you have to maybe negotiate from a spiritual point of view. And I remember when we had that discussion, I started citing a very famous text, which I think every person who has done philosophy, you know the story of Socrates and the symposium. And in between there, I think I quoted that time one of the statements. Yeah, it's you who presented, you remember? And I came up with this, whatever. That if you look at it, because I remember talking about the idea, like Socrates says that the entire life of a philosopher is preparing to die. And if you come to our local societies, when you go to funerals, that's where the discourse on death is usually brought up. And the statements you hear, like, we are moving corpses, which is not a very nice thing if you're not a poet. Because death will come at any time to anyone, to wherever. So should it be an issue of end of life care? I think it should be part of your spiritual dimension of daily care.
Just a second. Thank you. To go back to our days, I can tell you that palliative care doctors are the ones that have the lowest incidence of burnout. Okay, so it's much worse to keep hoping when that hope doesn't have the basis. Okay, doesn't have substantial data that give you the right to hope. Okay, so it's much better to conceptualize death, that can happen, is not a defeat, than to keep hoping for something, for a false hope. Okay.
Stephen, ask us a question that will finish us on a high, will you? I don't like the idea of being a walking corpse as I go down for my coffee.
Yeah, for me, I just wanted to understand how to this palliative care, how to make it realistic in the settings that, for example, where I come from. For instance, in one project of MSF, and in that community, there were two instances. There was one that the mother brought the child to the hospital, and the child was diabetic type 1, and he was in a critical situation. But on learning just getting the tips that this child definitely might not make it, she disappeared. And it was not only one mother, it was there are several mothers that does that. So one of the mother was asked by the HP teams later on. He said, after all, that child is going to die. I will go and produce another one. Yeah.
Okay.
Yeah. So in this case, how are you going to bring the aspect of death, of palliative care, how to care, and end of life care for such a setting, such a group of people that sees if you bring this, I mean, this child is going to die anyway, I'm going to produce another one. So,
Yes, that's an interesting perspective to take. Anybody want to take that, or shall I catch it?
I'm not sure I understood the question. So how do you approach like this mother that brings a kid where you think you don't have anything to do for him? Is that the right question?
how are you going to approach palliative care in this group of people that, with the moment they see the child or their patient almost maybe going to die, or there's a chance that this patient is going to die, they will definitely disappear. They will not come back. They will not care about whether you bury the person or you don't, because their idea is that they're going to produce another one.
Well, maybe at least start by not saying this one is going to die. You know, that's not the first thing to say. Okay, so what we say in palliative care, one of the quotes in palliative care is, when people say there is nothing to do, there is still a lot more to do. You know, so it's you if you focus the attention of your communication not on there is nothing to do, but yes, he needs to, he's suffering to be released, he needs to be accompanied and so on, and you approach the communication gradually. Okay, if you have obviously the time to do that, but even if you don't, even if it's in 72 hours, you have time to talk. Okay, obviously you need some skills to talk in the right way. Nobody's was born with those skills. You need basic skills. We use the spikes protocol, for example. So you need to set up a adequate setting to provide that communication. You need to understand what the person knows already about his situation. You need to invite that person to know more if they want to know more about their condition, and then you give communication in a certain way by providing empathy also, and by scheduling, a follow up. That's
Aware of the time, I'm going to finish that off. End of life care does not mean you're stopping. What you've done is set a ceiling of care so far, and that's as far as we can go. I don't ever recall saying to somebody, this patient is going to die. We will keep them comfortable, we will keep them hydrated, we will minimize their pain. They may die, but they may also pull through. What we are not going to do is escalate the care. I think it's really quite challenging to say your child is going to die. They can often, children bounce back. Elderly people bounce back quite dramatically. They catch you out. So we set a ceiling of care. We are not going to take them to intensive care. We are not going to put them on a ventilator, a breathing machine, whatever the right language is, because we do not believe that if they get to that stage, they are ever going to come back from that. But that doesn't mean we're not going to do everything we can to keep them comfortable. And it's about how you pitch. I hear the challenge. When I was planning this out and Diego's palliative care angle came in, I thought it's a great segue. When we deal with acute emergencies and you're given 50 major emergencies coming in immediately, you do the most for the most. If you have all those patients to treat, you want to identify the patients who are going to have the best chance of good success with the limited resources you have. And that's a really difficult technical skill. You need a lot of experience to be able to do that. Palliative care is as complicated. It's about making a judgment and planning what you're going to do, not about pulling out and not doing anything at all. For those of you who have any association with the UK, have you heard of the Liverpool Care Pathway? 15, 20 years ago, it was a big thing. And the Liverpool Care Pathway was what what hospitals put people on when they knew they were going to die. And public perception was that we'd stopped. And the families threw their hands up in horror. How can you stop? So the whole concept was binned. It was flawed from the start. But the position we now take is not we are withdrawing. We've set a limit. So it's a very different psychological position to be taken with the relatives and with the patient. But quite often when you talk to the patients, they know. This is as far as we're going to go. This is what we're going to do with you. And they're usually receptive to that. With that, can I thank my 4 panelists? Would you recognize our panelists? Ladies and gents, tea is served, and can we be back by 10 past 11, please? 10 past 11. Thank you.